Okay, our topic for today is regulation of the heartbeat. So the cardiac function, it is regulated by a number of intrinsic and extrinsic mechanisms. So the intrinsic mechanisms are the Planck start mechanism, which was discussed uh, during the introduction to the cardiovascular system. And next is uh, next is the rate induced regulation, and the extrinsic are the nervous and the chemical component. So the nervous system is composed of sympathetic and the parasympathetic, no? So the sympathetic are those that can increase the heart rate, the cardiac output, while the parasympathetic is the one that balances, no, the heart rate and the cardiac output and the cardiac function. So your extrinsic and intrinsic mechanism, it is the reflexes that regulate the heart rate. So it is composed of baroreceptors, chemoreceptors, pulmonary inflation, the vein bridge, which is located in the atrial receptor, and the ventricular receptors. The ANS, or the autonomic nervous system, it regulates the myocardial performance. Is Raj here? Tanari Raj? Your LO is here. Is
Yes,
Raj?
ma'am, I am there, ma'am.
Yes. I said I don't know what happened to the MS Teams. Probably because most of you are not member, no, of MS Teams. That's why there's a problem in the connection. So what I'm trying to do is I am recording now our lecture. I will just post it again in our classroom, so that those who will not be able to participate in this discussion will be able to see the lecture. Okay, so just
Yes,
tell,
ma'am.
no need to try to, because we already reached 100 participants, no? My Zoom can only accommodate 100 participants. So I already checked the attendance in our MS Teams a while ago. So no need to attend this, but they need to view my lecture later, no, once I posted it. Okay? So to continue,
Put their attendance, ma'am.
yes,
Their attendance.
attendance. I will also post attendance in Google later. Okay? So
Yes,
the autonomic nervous system regulates the myocardial performance, which is varying the calcium conductance of the cell membrane and via the adenyl cyclase system. So the hormones that regulate the myocardial performance are the epinephrine, adrenocortical steroid, thyroid hormone, insulin, glucagon, and anterior pituitary hormone. So if you are already doing your clerkship, no, you will be able to see the epinephrine, which are responsible for increasing the blood pressure, especially in patients with hypotension, and also in patient with bradycardia. No, we use epinephrine, and we use epinephrine for those who have dysfunction in the heart rate, no, so especially those patients that are near coding or near mortality patients, no. Next, so your intrinsic mechanism, which was already discussed in the previous lecture, this is your Planck's Starling law, which affects the increasing afterload on the steady state of the left ventricular pressure loop, and heart rate and inotropy held constant. So the ones that are changing are the afterload in the left ventricular pressure. Next, so the Planck-Starling mechanism is the process by which a change in the resting length of the myocardial fiber influences subsequent contraction by alternating the affinity of the myofilaments for calcium and by alternating the number of interacting cross bridges between the thick and thin filament. So I think the interaction of your thin and thick filaments was already discussed in the cardiac muscle. So we will not deal more on that. So your excessive highly feeling pressure that overstretch the myocardial fibers may depress rather than enhance the pumping capacity of the ventricles. So this is the one that are rate induced regulation. It sustains the change in the contraction frequency that affects the strength of contraction by altering the rate of influx of calcium into the cell. So the transient change in the contraction frequency alters the contractile strength because of an appreciable delay that exists between the time and that the calcium is taken up by the sarcoplasmic reticulum and the time that it becomes available again for release. So this one is responsible, no, for the contraction of your sarcoplasmic reticulum. So the substance that are responsible for the function of your for the function of your sarcoplasmic reticulum is your calcium. So the calcium is the ones that is responsible for the binding of your actin and tin filaments. So, as I said a while ago, your heart is also the extrinsic factor that responsible for the heart is the autonomic nervous system. So, both the division of the autonomic nervous system tonically influence the cardiac pacemaker, no, the SA node. So, the SA node, we call it the pacemaker. So, your sympathetic nervous system enhances the automaticity while your parasympathetic it inhibits the changes in the heart rate, usually involves in the reciprocal action of those two divisions. So parasympathetic tone usually predominates in the healthy resting individual. So in a healthy individual, usually the more prominent autonomic system is the parasympathetics. That's why there is a resting heart, no, has resting heart rate. I mean, so for those athletes, the most common heart rate for them is bradycardic, no. So next, so for parasympathetics, effects of vagal activity on the SA nodal function have a very short latency, which is about 50 to 100 milliseconds. The one that is responsible for your parasympathetic is the release of your acetylcholine that quickly activates the special acetylcholine regulated potassium channels in the cardiac cells. So the channels open quickly in response to ACH or the acetylcholine, but no intermediate second messenger system is required. The second messenger system is the adenyl cyclase system. So next, the sympathetic response or stimulation decay only gradually after the stimulation is stopped. The onset of cardiac response to sympathetic stimulation is slow for the two main reasons. Because your norepinephrine appears to be released slowly from cardiac sympathetic nervous system. So the onset of the cardiac response to sympathetic stimulation is slow for two main reasons. So as I said, no, it was slow because of the release of your norepinephrine. Then next is neurally released norepinephrine mediated mainly by a slow second messenger system, which is the adenyl cyclase system. So the brain is the control uh, of your most of the function of the heart, no. So it is located in the cerebral cortex, frontal lobe, orbital cortex, motor and premotor cortex, anterior part, temporal lobe, insula, cingulate gyri, anterior, posterior, and posterolateral hypothalamus. So, the baroreceptors, so these are the sudden changes in the arterial blood pressure that initiates reflex that evokes an inverse change in heart rate. So the baroreceptors in the aortic arch and the carotid sinuses are responsible for the baroreceptor reflex. So it is known that the pressure in the baroreceptors are about 70 to 160 millimeter mercury to 100 to 180 millimeter mercury. So this is the vein bridge, no? Reflex, your atrial receptors and the atrial natriuretic receptor. So what is vein bridge? Brain bridge reflex is when the heart rate was low, IV infusion usually accelerated the heart. At a more rapid heart rate rates, infusions ordinarily slowed the heart rate. So it increases in blood volume, not only evoke the so-called vein bridge reflex, other reflexes activated tend to elicit opposite changes in the heart rate. So there are two reflex, your baroreceptors and the chemoreceptors. So the heart rate as a function of the mean arterial pressure. So in this diagram, you will note that the higher the arterial pressure, the lower the heart rate. No, so it that they are inversely proportional. So when your arterial BP is 150, you usually have a lower heart rate, no? So if you have a high heart rate, you usually have a low arterial BP. So the formula for your cardiac output is equals to heart rate times the stroke volume. Okay. What is the atrial natriuretic peptide? So this is a stretch of atrial walls that releases the ANP from the atrial tissue. ANP exerts potent diuretic and natriuretic effects on the kidney and vasodilator effects on the resistance and capacitance blood vessels. So important regulator of blood volume and blood pressure. So, ventricular receptor reflex. Sensory receptors that are located near the endocardial surfaces of the ventricular walls that initiate reflex. So, excitation of these endocardial receptors diminishes the heart rate and peripheral resistance. Implicated in the vasovagal syncope, feeling of lighted headedness or brief loss of consciousness that triggered by psychological or by orthostatic receptor. So, the one that is responsible for the vasovagal syncope are the ventricular receptor reflex. So, there are also chemical control, no? As I said, your chemical control are your thyroid, insulin, no, and other hormones. So first is the thyroid hormone. So numerous studies in intact animals and human demonstrated that thyroid hormone enhance myocardial contractility. It increases the protein synthesis in the heart, and this leads to cardiac hypertrophy that exerts by genomic and non-genomic means. So, this is your insulin. So this is a positive inotropic effect on the heart. So potent positive inotropic and conotropic effect on the heart, like your insulin, is also your glucagon. So this is the cardiac effects that activate the adenyl cyclase to increase the myocardial tissue level of cyclic AMP. It increases the calcium influx to the calcium channels in the sarcolemma and facilitates the calcium release and reuptake by the sarcoplasmic reticulum. Next, your anterior pituitary hormones. This is composed of the growth hormones, which does not affect the myocardium, at least with the combination of thyroxine. So, the growth hormone needs to be combined with thyroxine for it to have its function in the myocardium. So, when the blood volume or peripheral resistance increase, thyroxine alone does not restore adequate cardiac function. But if it is combined with the growth hormone and thyroxine, so thus establish the normal cardiac performance. So next, the blood gases. This is is exposed to moderate degrees of hypoxia, heart rate, cardiac output, and myocardial contractility. So once the patient was exposed to severe hypoxia, so the heart rate will increase, the cardiac output will also increase, as well as the myocardial contractility. So the effect of hypoxia is biphasic. So if the patient have mild hypoxia, it can stimulate, no, but more severe hypoxia, it is depressant because of the oxidative metabolism is affected. So what happens is, if the patient is mildly hypoxic, usually the heart rate is increased. Once the patient becomes severely hypoxic, example, the saturations become less than 80, no? So the patient become severely hypoxic. So the effect of that will cause bradycardia and eventually hypotension. Then eventually the heart will stop. Next, so increase in the systemic arterial PCO2 stimulates the central and peripheral chemoreceptors, that leading to generalized increased sympathetic neural activity. So acidosis is also detrimental to the muscle. So in this diagram, you will notice that the as the pH increases, no, the stimulation of the arterial chemoreceptor is also increased. And once the pH decreases, no, the more the acidotic the pH, the more detrimental to the heart. Diminishes the amount of calcium released from the sarcoplasmic reticulum, also decreases the sensitivity of the myofilaments to the calcium. So it means that if the blood gases is more acidotic, the release of the calcium in the sarcoplasmic reticulum diminishes, and in effect, it will also decrease the sensitivity of the myofilaments to the calcium. So the myocardium will become acidotic and eventually will cause decrease in the cardiac output and also decrease in the heart rate. Next, the cardiac function. So the cardiac function changes in the arterial blood concentration of oxygen, your CO2, and your bicarb. So which is directly alter the cardiac function and indirectly alter it via the chemoreceptors. Um, your this topic, I got this topic from Byrne and Levy. So for your exam, I'll be getting Byrne and Levy for this topic. And for the first topic, the one that I share with you via Zoom, the recorded topic, the first topic, I will be getting your exam from the Guyton, as well as the rhythmic function of the heart. No, so I will just share with you. I am sharing you that I will be getting exams from the two books. Okay. Any questions regarding this topic?
No, doctor.
Okay. So the next topic is the properties of the vasculature. So these are the components, no, of the vasculature of the heart. It is composed of the arterial system, the venous system, and the microcirculation. Wait lang.
Doctor.
Yes.
Uh,
Okay, to continue, so the circulation is divided into systemic circulation and pulmonary circulation. So because the systemic circulation supplies the blood flow to all the tissues of the blood except the lungs, and it is called the greater circulation or the peripheral circulation. So the vasculature consists of a closed system of tubes or vessels that distributes blood from the heart to the tissues and return blood from the tissues to the heart. It can be divided into three components, which is the arterial system, which takes up the blood from the heart and distribute it to the tissue. the venous system, which returns the blood from the tissue to the heart, and the microcirculation, which separates the arterial and the venous system and is the site where nutrients and cellular waste products are exchanged between blood and tissues. So these are the functional parts of the circulation. So the arteries are responsible for the delivery of the oxygenated blood to the organ. So once the unoxygenated blood from the pulmonary circulation, it will be delivered to the left heart via the pulmonary veins, via the left atrium. So it will enter the left ventricles, then it will enter the aorta to be distributed to the different parts of the body. So the arteries are thick-walled and it is under high pressure, and it is have a high volume, or we call it the stress volume. While your arterioles are the last small branches of the arterial system, they act as the control conduit through which the blood is released into the capillaries. The arteriole has a strong muscular wall wherein uh, that it has a strong muscular wall that can close the arteriole completely or can be dilate it several fold, thus having the capability of vastly alternating the blood flow in each tissue bed in response to the need of the tissue. So next, the capillaries are responsible for the exchange of fluid, nutrients, electrolytes, hormones, and other substances between the blood and the interstitial fluid. So, to serve the role of the capillary walls, it is very thin and have numerous minute capillary pores, which are permeable to water and other small molecular substances. While the venules collects the blood from the capillaries and they gradually qual into the progressively larger veins. Next, veins. So the veins are function as a conduit for transport of blood from the venules back to the heart. So it has a lowest pressure compared to your artery and has a highest proportion of blood into the cardiovascular system, and it is unstressed volume. Next, so the basic principle of the circulatory function is the rate of blood flow to each tissue of the body is almost always precisely controlled in relation to the tissue need. The cardiac output is controlled mainly by the sum of all the local tissue flows. The arterial pressure is controlled independently of either local blood flow control or cardiac output control. In general, the arterial pressure is controlled independently of either local blood flow control or cardiac output control. So the rate of blood flow to each tissue of the body is almost always precisely controlled. So the cardiac output is controlled mainly by the sum of all the local tissues. The arterial pressure is controlled independently of either local blood pressure or cardiac output control. So these are the interrelationship among the pressure, flow, and resistance. So this is the physics of blood flow through the vasculature. So it is controlled by the pressure difference, pressure gradient, and the vascular resistance. So the pressure difference of the blood between the two ends of the vessels are also sometimes called the pressure gradient among the vessel, which is the force that pushes the blood through the vessels, and the vascular resistance is the impedance of blood flow through the vessel. So this is the formula for the velocity of the blood flow that can be expressed by the following equation. So V is equals to Q divided by A. So your B is the velocity in cm per second, Q is the blood flow in ml per meter, minute, and A is for the cross-sectional area in cm. So the normal value, the overall blood flow in the circulation of the adult person of normal adult person at rest is about 5,000 ml per meter minute, or sometimes we compute it as 5 liters per minute. So this is called the cardiac output because it is the amount of blood that pump into the aorta by the heart each minute. So next, so the blood flow can be expressed by this formula. Q is equals to change in pressure divided by the R. So Q is the flow, change in pressure is the pressure gradient, and R is the resistance. Blood flow can be expressed by the formula. The pressure gradient derives the blood flow. The blood flows from the high pressure to low pressure, and flows is inversely proportional to the resistance flow. Next, so this is the Poiseuille's equation, which is equal to the resistance is directly proportional to the viscosity of the blood. So viscosity of the blood is mainly the large number of suspended red cells in the blood, each of which exert frictional drag against adjacent cells and against the wall of the blood vessel. For example, increasing the viscosity by increasing the hematocrit will increase the resistance and decrease the blood flow. So the viscosity of the whole blood at normal hematocrit is about 3. This means that 3 times as much pressure is required to force the whole blood as I force water through the same blood vessels. So the resistance is in series. This is the arrangement of the blood vessels within a given organ. So the resistance is the your vessels is composed of large artery, then small artery, then arterioles, then it will go to the capillaries, then veins, which is arranged in series, no? So the sum of the individual resistance equals to resistance of the artery plus the resistance of the arterioles and the resistance of the capillaries. So, resistance in parallel, this is the systemic circulation of each organ, which is supplied by the artery that branches of the aorta. So, the total resistance is less than the resistance of any of the individual arteries, with the exception of capillaries in the renal and the splanchnic vasculature. So, this is another property of the vessels, no? It has a laminar and turbulent flow. The laminar flow or the streamline flow, it is the flow of blood through a long, smooth vessel, and the turbulent flow flowing in all direction, forming a whirls. So, if there is a hole or there's a stenosis in the vessel, it can have the turbulent flow. So the normal flow for a vessel is we call it the laminar flow or the streamline flow. So the vascular distensibility, uh, this is equals to the increase in volume divided by increase in pressure times the original volume. This is the amount of fractional increase in volume for each millimeter of mercury rise in pressure. So arteries are about 8 times less distensible than the veins. Next, the capacitance and the compliance. So the capacitance or compliance is the total quantity of blood that can be stored in given proportion of the circulation for each millimeter of mercury pressure rise. So the compliance and distensibility are quite different. So a highly distensible vessel that has a slight volume may have far less compliance than much less distensible vessel that has a large volume, because compliance is equals to distensibility times volume. So the arterial system. So your arterial system, so there are two factors, no? The physiological and the physical factor. So the physiological factors are the cardiac output, which is equals to heart rate times the stroke volume, and also the peripheral resistance. while the physical factors are the arterial volume and the arterial compliance, which all of this have effect in the arterial blood pressure. So the mean atrial pressure, we call it the MAP. This is the pressure that average over time. So this is the systolic and diastolic arterial pressure within the cardiac cycle. So the MAP, or the mean arterial pressure, is the pressure that are uh, pressure average that between the systolic, which is the maximal, and diastolic, which is the minimal arterial pressure within the cardiac cycle. The difference between the systolic and diastolic is termed the pulse pressure. Okay. So the factors that affect the arterial pulse pressure are the stroke volume and the arterial compliance. So there are ways in measuring the blood pressure. There are auscultatory methods, and there is also Doppler method. But uh, the more accurate and the more widely used are the auscultatory method. So we usually use a sphygmomanometer. So it has a required width and length. So it should be 40% of the limb circumference, which is about 12 to 14 cm, and the length should be 80% of the limb circumference. And in taking the blood pressure, the patient should be taking rest for at least 5 minutes, and those patients should avoid smoking and ingesting caffeine 30 minutes before taking the blood pressure. So, so it is placed in the antecubital crease, no, which is at the level of the fourth ICS. So lower border of the cup is supposedly 2.5 cm above the antecubital crease. So estimate the systolic pressure by palpation of the radial pulse. Then inflate until the pulse disappear. Then manometer pressure plus 30 millimeter mercury. So deplete the cup promptly and completely and wait for 15 to 30 seconds. Okay, next. So the venous pressure, we usually get the venous pressure by inserting a catheter in the, sometimes we insert it in the SBC, no? So the normal pressure is between 8 to 12 CBP. So the factors that influence the CBP are the ability of the heart to pump blood out of the right atrium and ventricle into the lungs, and tendency for the blood flow from the peripheral veins into the right atrium. So the factors that increase the venous return are increased blood volume, increased large vessel tone, and dilatation of the arterioles. So the effect of high right atrial pressure on the peripheral venous pressure, blood begins to back up into the large vessel. So collapse points upon open up at positive 4 to 6 millimeter rise in pressure. Additional increase causes rise in the peripheral venous pressure in the limbs. So, during recumbent position, there is a positive 6 millimeter mercury, and also increase in the intra-abdominal pressure can also increase the pressure in the venous pressure. Example of that are pregnancy, large tumor in the abdomen, and ascites. So intra-abdominal pressure is about 20 millimeter mercury, which is increase in the femoral veins of about 20 millimeter mercury. Okay, so in this figure, this is the venous pump or the muscle pump. So there are valves in the veins that make sure the direction of the venous blood flow is towards the heart only. So the function of your venous pump is towards the heart always, no, not against the heart. So this is an example of a incompetent valve. This is the example of the varicose vein, which are large bulbous protrusion beneath the skin. The treatment for that is usually supportive, but if the varicose vein are so large, they usually do sclerotherapy and also laser therapy, intense pulse therapy, and also vein surgery. Next, microcirculation. So, microcirculation is the circulation of blood through the smallest vessels of the body, arterioles, capillaries, and venules. So, the functional properties of the capillaries, it has a vasomotion motion function which is intermittent contraction of the meta-arterioles and precapillary sphincter, which is regulated by the amount of tissue oxygenation. So the lower the oxygen, the increase in vasomotion, the longer the duration, the increase in perfusion tissue. So the transcapillary exchange is about 300 ml water per minute per 100 grams of tissue. It has a transcapillary exchange of solute. So the lipid soluble, insoluble molecules are can enter the transcapillary exchange and also the water filled channel. So the difference between the two is the water, the sodium chloride, the urea, and glucose are flow limited, and the larger molecules are diffusion limited. So the lipid soluble molecules, example of that are the oxygen and carbon dioxide that are can only enter those that are poor lipid membrane or those that only that allow the lipid soluble substances. So the capillary filtration, it is usually composed of uh, not uniform vessels. Example of that is the liver capillaries, which are more permeable than the muscle capillaries, and the venous ends are more permeable, which has the greatest in the venules, and it occurs through the capillary apertures, pores, fenestrations, and discontinuous endothelium. So hydrostatic and osmotic pressure, it is a increase in hydrostatic pressure filtration. So increase in venous, in effect, it increases the arterial pressure that will increase the hydrostatic pressure. So, increase in the protein concentration in the blood favors the filtration out of the capillaries. The lymphatic system. So it has an absent tight junction in between the endothelial cells, spine, filament, anchorage. So it usually drain in a larger vessels in the left and right subclavian veins. It is also the volume of fluid that transported through the lymphatics in 24 hours is about equal to the body total plasma volume. So, the effect of lymphatics that return about fourth to half of the circulating plasma proteins to the body in a day. If it is if the capillary is have a problem, we call it the edema, and those that filters the lymph and then removes the foreign particles, there are the thoracic duct and the chylomicrons. Okay, so for the best for this one, I'll be getting your exam from Burn and Levy also. So for